here to introduce a couple of awesome guys. So on my left here is Dr. John. He has been a physician in the Des Moines area for many years, and like many of us, older docs kind of has, I like to call it the wounds and scars and stripes and stars on our shoulders from fee-for-service primary care, where we were in the trenches for years, and he stepped away from that years ago and has an awesome DPC practice in Des Moines. Sitting next to him is Mike Patton. Mike is just a few miles from us in Colorado, in the Boulder, Longmont area. And although he's, I think, kind of headquartered there, he's got his hands in a number of other places across the country. And today they're going to talk about something that's pretty darn cool, and that is how do you put direct primary care into a health benefit plan, right? Like I tell people, think of it like you've got this health benefit home, who's a general contractor? And then what do the subs look like? What do those rooms of that health benefit home look like? And Dr. John's room is the DPC room, and then the general contractor could be Mike putting all those pieces together, because there are a lot of innovative solutions, and at the end of the day, what provides really good care, and then what is affordable. So you guys have the mic, and I think there might be some time for Q&A afterward.
We're planning on saving time for Q&A, so Mike, fire away.
All right, nice to meet everybody. Like Dr. Flanagan said, my name is Mike Patton. I'm the president of XL Health Plans. We are as he said, we're based in Denver, and we're a progressive benefit plan focused on what we call a proactive PPO approach, which makes a PPO plan function for everyone in here who's a provider much more similarly to a managed care plan than it does to your traditional PPO with no cost containment. And I'll let Dr. John introduce himself.
Hello, I am a general internist by training and a recovering fee-for-service doc who does direct primary care for a little over 4 years. I broke free from the industrial medical complex. So I started and run Exemplar Care in Des Moines, Iowa, as was mentioned. And I'm curious for our sake, so that we talk about the right things to the most people, who here is a physician or practitioner or clinician or provider? Very good. How many are DPC already? Okay. And then who are point solution vendors, different folks in that area? Very good. And brokers, insurance? Very good. Okay. That gives us an idea of who's sitting here, so thank you all. Mike, why don't you go ahead and kick us off?
All right, awesome. So the purpose of this conversation is really for us to dive into, like Dr. Flanagan said, how important it is to have a health plan which complements and fits with direct primary care, and how important that is. As we've seen, and as a number of people in this room have noticed, it can be very difficult to scale direct primary care. And as we all know, part of that challenge just relates to the fact that, as we all know, healthcare is extraordinarily expensive. It's more than quadrupled since the year 2000. So because of that, most of that burden is being borne by employers. And it can be very difficult, to be frank, from a sales standpoint, to sell to a company, hey, you should pay $100 a person a month for primary care, when they already can't afford to pay for their employee benefits currently. So the purpose of this talk is to show you how, by integrating the two approaches together, you change the ROI proposition, and it significantly reduces, the overall net overhead onto the employer groups, and then how to go about presenting that, selling it, scaling it. That's the purpose of this conversation.
And I just want to throw in there quickly for the folks that are doing DPC. I've had conversations with other folks who've been on panels already today about there's the kind of the DPC and name only dino thing that's out there. So there are purists who DPC cannot interact with insurance. They only interact with patients. There's all sorts of gradations across the spectrum. Historically, when you look at the development of the DPC movement, and I always say I started off as a purist thinking I'd have a small footprint, but then I had an employer group who came to me knowing that they needed my care and solution for their employer group or for their employees, and it was like, oh, well, this seems like a no-brainer. I have 25 patients, I should probably take the next 200 that they're wanting to work with. I mean, when you're brand new at this and you're watching the account turn deeper and deeper blood red, it was an easy decision to make. So we wanted to talk about some of the benefits of putting these things together. And I'm going to start with a convenience store chain that I work with. And they were the group that came to me at that time through an on-site, near-site middleman, which was an interesting story. But they came looking for direct primary care in the Des Moines area because their near-site clinic wasn't financially viable for what they were doing. And they knew that their employees needed dedicated resources. Their benefits package is one of the reasons why you have people turning 40, 50 years in the convenience store was because of their benefits and their compensation. So they really cared about this being front and center. And the first year we got up and running, had about 250 of their 400 market employees on the plan that integrated us with their plan. And 9 months later, I got the 90-day notice that they were terming us and running away. So you might be wondering why I'm telling a failure story. The reason that DPC for the win, as you often see on LinkedIn, was the employees who had met me went to their HR benefits person and said, hey, this is the best care experience we've had in the last 6 or 7 years. You've switched providers on us year after year. And they went to bat for me as a brand new DPC up and running. And they called and said, well, financially, you don't make any sense to us. You cost too much per visit compared to the fee-for-service world that we could get. And I said, well, you must not be talking about money that I'm getting. And we came to find out that the near-site clinic was twice as expensive as what they were paying me. So they were taking 50% off the top and passing that along to this convenience store chain who went, well, oh, if you're half that price, you make perfect sense. And we've been working together ever since in a fantastic arrangement where they trust me to take care of contracts for imaging. So they have their own contracts, but they'd let me practice DPC as though they're as just individual members, and it's really been a fantastic point. But the point of that is that short-term benefits to having direct primary care integrated into a plan is that patient experience is otherworldly. And so as rates only go one direction, no one's ever seen their rates go the other way. Mike might try to change that. But as you watch rates go up and cost go up, having something that's valuable to those employees, it's what maintained us was the value we were providing.
That's awesome, Dr. John. So one of the stories that I am going to tell here real quick and just how the plans can fit together in the short-term ROI gains is a really good friend of mine, benefits consultant out of St. Louis named Adam Berkowitz, owns a firm called Simpara HR. Adam's actually speaking here this week, and he has a DPC client with a DPC firm out of St. Louis as well called Resilient Health. They have a little bit different model than traditional DPC, but effective nonetheless. They worked with a company called Cosmos and installed it last year, and they were able to get participation levels of over 25% of the members to engage and sign up for the direct primary care visit and have ongoing engagements of north of 15%, as in north of 15% of the population engaging every single month, which is really good direct primary care engagement. And off of that, they're able to see annualized savings of over $250,000 directly related. There's Adam right there, and directly related to the to what they were able to do by building the DPC clinic in with the health plan. What it allows the plan to do is to say, okay, this is a self-funded plan. So for all of you guys out there, self-funding means that you're just breaking up a health insurance plan into specific components. Administration, like there's companies you probably see, Jay Kempton, and heard the name. His company is a third-party administrator, so they administer and pay claims. There's benefits consultants. They obviously charge a fee. There's stop loss insurance. All that is basically split in half. So just think about it. Your health insurance plan is broken into two. You have a bucket for claims and you have a bucket for administration and premium. So whatever you don't spend in claims, the companies get to keep. And that's where the ROI is generated back for the plan. So when this company doesn't spend that $250,000 annually, they get to keep it at the end of the year. So for you all as direct primary care providers, whatever you're doing to help those members go to specific high quality, low cost locations, which is a lot of what we do. We have people up front here from Surgery Center of Oklahoma. So if a member of a health insurance plan needs we love to throw this on our sales calls, needs a total joint replacement. Surgery Center of OK charges, between 17 and 18,000 for knees or hips, depending on which you're picking. And if you do those inpatient in a hospital in most settings in this country, you're looking at easily $80,000 to $130,000. So you can see pretty quickly how if a direct primary care provider like Dr. John or like what Mr. Berkowitz is doing with Resilient can make one member on one plan year on a 150 life group go get a hip replacement at Surgery Center of Oklahoma instead of inpatient at any of your traditional large hospitals. You're talking saving more than 50% of the total premium on the plan for a 150 person company, which is a pretty sizable employer. So that's how impactful direct primary care can be on a plan, because I worked in my mom's primary care office, and that's actually what led me into the benefit space, was a $600,000 pacemaker claim off a medical error. And the guy was inpatient for a number of weeks because of sepsis. And Dr. Smith told me this morning they used to charge about $8,500 for the surgery, and it's about 10 grand for the device back when they used to do them. So that's what really irritated me, but it doesn't take much, is my point, in order to generate that ROI back and allow a company to save a lot of money, which would easily pay for the cost of direct primary care.
So moving on to some of the mid-term as well as still short-term, depending on whether you put it 2, 4, or 5 years, where those definitions are. You really start to see behavior start to change when you implement direct primary care into a health plan. So the average person, historically, national data is like 1.3 visits to a facility per year for primary care visits. DPC, it's between 4 and 5 times annually. So the engagement rate, which Mike already touched on, goes up drastically. And as that benefit grows and as you get to know these people, they grow to trust you more. They come to you first. They take your recommendations rather than going to the ER. So I have 2 examples. One's with the same convenience store. In now 3 years, we've had 3 ER visits out of their 250 lives. So part of that is if they go to the ER before they come see me, the claim doesn't get paid. So they have a cool benefit design, which, as he said, every year they come in under their budget. They actually give a premium check back every May to their employees, which is super cool. Not many people are doing that. But they know that unless they're having what is defined as an emergency, they had better go to their regular primary care office. And part of their request with us was that we build out more robust services. So in addition to our routine primary care clinic, we've also added in a 24/7 urgent care. So this is where a lot of that ER avoidance goes. And we have anywhere from 10 to 15 of their employees visiting us between 8 p.m. and 6 a.m., which is when the other systems in Des Moines have no other access besides emergency rooms. And as a former hospitalist now recovering into primary care, if you don't go to an ER, you don't get admitted to a hospital. If someone who knows you and cares about you gets a hold of you, the last place they want to send you is to a hospital. So by putting that solution in, you can keep people out of the highest spend areas, which, there's meds, there's all sorts of procedures, but again, nothing's quicker than going into a hospital setting to chew through money. And I'll save the last example for when we get to the long term.
Awesome. Yeah. And the example that I was going to bring up, and what Dr. John just touched on already, is the importance of the way the plan is built and functions in terms of the member behavior. So when I was working at my mom's office, what I realized is that most of the patients that would come in, they would do whatever we recommended. Nurses are the highest, most trusted people in the U.S., and doctors, especially primary cares, are second. So doctors have a very strong behavior, basically power over what people will do, and they trust their doctors.
I prefer the term influence, not power.
There we go. But it turns out the same either way. But anyway, so what happens is like when I was at my mom's office, we literally would refer people based on who gave us the best lunches. So whatever surgeon's offices brought in the best lunches for the staff, that was who got the referral. So it's very, very scientific, only quality. That was the only thing that mattered. And after understanding that, we started engaging with members to offer them no cost sharing, which is very important in terms of getting members to engage. If you're working with a fully insured BUCA plan and your direct primary care sitting next to that plan, there's no incentive. My dad had his hip replaced in 2019 and it cost $130,000 at Littleton Hospital. And that same provider actually is in network with Coral, and you can go to a bundle about 4 miles from the hospital that he had the surgery done, and you can get that surgery done for $22,500 from the same guy. But my dad is on a health insurance plan from Lockheed Martin, which is not built to provide him any incentive to go there. And the problem is that it would have cost him the same $5,000 at either Littleton Hospital or Dry Creek Surgery Center for his procedure. So there's no incentive for him to care. So we just created $130,000 or $110,000 of healthcare waste for no reason, because there's no incentive for him to go to one location versus the other. So when direct primary care is involved, members and, on our plans, we offer this no deductible option, and we find that the rate that members accept the $0 option doubles when we're working with a direct primary care provider. So,
So we've seen with that when there's no additional cost, no copay, nothing out of pocket for them to come and see us, that in year one, you might get 25, 30% of an employer group to come on board, and then it goes to 50 and roughly 80 by the end of year 3, because they start hearing word of mouth, oh, this is awesome, I went here and it was open in the middle of the night, and I didn't have a copay, I got meds dispensed to me, I had my x-ray on site, and none of these things cost. It doesn't take long before the workforce starts talking to each other. So when you can design it so that there's no out-of-pocket to the employee, which we've all seen what premiums have done and what moving to high deductibles has done, people are functionally uninsured again. And a lot of them don't even understand that their preventive services are covered. So they're ignoring all of these things. Sorry, I stole that.
No, that's great. We can move on to the midterm gains if you want to, Dr. John, on what's your Medicaid story?
Yep. So as a fairly unique thing in the DPC space, I actually have a contract for 6,000 lives with Medicaid, similar to what Q Alliance did way back in the day, and it's paid and functional just like direct primary care is. So one of the MCOs in the state of Iowa contracted with us to take care of people for us at PMPM, and we treat them just like, I say I take care of my Medicaid population the exact same way I take care of CEOs of Fortune 500 companies. And it's a really cool way when you change the financing in care, you can change the way the care is delivered, and it all becomes a wash, and everyone can be treated exactly the way they should be treated. Now, why would they do that? Why would we do that? I'm a true believer that those who assume the risk are assuming the risk because they know they're going to get paid for it. So as a direct primary care clinic, we said we want upside and downside risk with them. And through our first year with their population, which we knew roughly what the size and scope of the risk scores were going to be for them, we are going to be just over $2 million in upside payment this year, which more than doubles what we made on the PMPM standpoint. But again, I always say if you look in Des Moines, Iowa, Wellmark Blue Cross Blue Shield has the biggest, nicest building for a reason, and it's because they assume risk that they've accounted for and that they try to help manage. Why are we letting them have all of that money and risk when you're the one who has to manage, as a primary care doc, you're managing that risk on their behalf and they're making all of the benefit. So in this case, in a Medicaid space, we could go at risk and actually do the exact same thing and reap the benefits from that. So that's an area where I really feel passionately that the provider side has kind of moved away from that. And in DPC, you're taking better care of people, you're spending more time with people, you're sending them to more cost-effective solutions. And why on God's green earth you're letting someone else make the money off of that risk makes no sense.
That's a really good point, Dr. John. Yeah, many of the BUCA carriers, as well as companies like Centene and obviously United Healthcare, are some of the actually the biggest Medicaid providers in the United States. And there's a lot of money in that space, and a lot of these same concepts are actively deployed. That's kind of always the interesting thing that you find being in the space, is that these carriers understand managed care when they're at risk on things like Medicare Advantage and Medicaid populations, but then they behave completely the opposite when they're working with their commercial products, no different than the plan designs, because their incentives are different. So their goal with the employer is to, because of the medical loss ratio, is to drive the cost of healthcare as high as possible, which they do. So
as you all know, 80% of a bigger number leaves 20% of a bigger number, which is more profit. I mean, if you look at United's, what would they go up 900% in the last decade on their stock price? So it's leading the marketplace.
Yep. Yeah. Their stock price in 2015 was in the $120 range. It's, I don't know, somewhere between $450 and $475 right now. It's been over $5 this year. So they're not hurting at all. But one of the last stories, and probably the most impactful one of direct primary care in existence, is Rosen Hotels. So Harris Rosen is one of the most innovative people in terms of health plan builds over the last 20 years. They own a hotel chain in Orlando, Florida, where they have between 5,000 and 7,000 employees, kind of like, a bunch of Fairfield Inns, a bunch of Courtyards, and a few Marriott's, JW Marriott's, all associated in one spot. So what they did, because they were going broke paying for benefits costs, the first thing they did was build the clinics and take over that primary care and bring it in-house. They have a couple clinics down there that they call Rosen Care. They started importing drugs internationally using many of the same programs that most benefits consultants here do, and a couple vendors. They also started using bundled surgical care, redirecting people to them, and eventually established direct pricing with a few of the hospital systems in Orlando at a very low percentage of Medicare, and redirecting all the members there. And after having done that for 13 plus years now, they spend less than 1/3 of the national average of companies, and they have no deductible and no out-of-pocket for their members if they go to their primary care first. So that's how rich their benefits are. I mean, the average deductible right now is over $5,000, and they have none. So that tells you how much richer their plan is than everyone else, and what is possible if you manage care, like Dr. John said, for a long enough period of time. You establish a culture where the members of the plan expect to go see that direct primary care, and then will then expect to go wherever that direct primary care sees fit. So if you establish a culture and a company is willing to make that level of investment, you'll see a long-term net gain tremendously.
So we are right at the time. I know we started a couple minutes late. I have more stories, but I would love to open this up for questions. If you're in the DPC practice space, I highly recommend connecting with Mike and talking about what Excel health plans are doing in your area. It's a really cool way to provide care and to, still have new members coming on and building out those relationships, and they do a good job taking care of us.
Hi, I have a question for you. How feasible is it for an employer that's not using DPC currently to incorporate DPC into their benefit plan without the cost of what they're paying over the last few years going up?
Well, and that's exactly what we're discussing kind of with XL Health Plans, or if you're working with a benefits consultant like Adam, we're able to obtain RFPs where frequently, on our stop loss on our plans, we get roughly a 10% discount on the cost of the insurance on the back end, which doesn't always cover 100% of the cost of direct primary care, but it can cover most of it. And sometimes using our different plan designs, we're able to net even the total cost up front, which is usually what we aim for, and then look to save money, as we talked about with that ROI with the self-funded plan. So that way the employers aren't eating money up front.
And that's been the problem from a DPC sales standpoint is if you go into someone who's fully insured with a BUCA plan and you say, well, here's our additional thing, they view it as an additional cost. And if there are savings, you're saving the plan dollars, not the actual employer. So shifting to these self-funded plans that are structured, they have all the components in, they just shift that over to the stop-loss carrier for the risk. It really makes a difference in how you can design that and you bundle those pieces together.
Hey, thank you for a great talk. My question is regarding what you were just talking about in terms of a plan that has no out-of-pocket for members that go to the DPC doc first. What does that do as the DPC doc? How does that affect your autonomy? Do you still have full ability, full autonomy to recommend and do what you want for your members, for your patients?
Yes, so getting this off the ground is kind of the fun part. Mike doesn't know the Des Moines healthcare landscape any better than any of you do. So he comes into a DPC practice and says, okay, what are your referral patterns? Let's go bundle with your favorite providers. Okay, we can confirm these are high quality people. So my ability to send people to who I want is completely uninterrupted at this point. We have a background network so people can go anywhere. But it doesn't impact the care I deliver at all. Now, there are times, and part of this, said a lot of people go into DPC for themselves and to change how they do things. So do I occasionally do a prior authorization to help get something like Humira moved from, 8 to 10 times what it can be if I fill out the paperwork and help a member do that? Absolutely, I do that, but I also see a fraction of the people I see every day. I have time to do that. So there are things I do, but I view that as part of my service to the member is it's saving them out of pocket money. And I don't separate care and cost. I can break people by sending them to the wrong places, and I know that. And we don't need any additional medical bankruptcy. Somebody over there?
Do you guys get approached by brokers and employers who say, I'm going to bring you X amount of lives, but I need you to discount your prices if I'm going to bring that because they know that certain people are just not going to show up? What's your response to them?
So from our perspective as benefits consultants and plan builders, I can assure you that conversation with stop loss carriers is pretty persnickety, and they're pretty much, they are where they are, and they'll give you roughly a 10% discount for incorporating direct primary care, and that's pretty standard, and they're really not going to budge on that. They don't care typically how much volume. They're not going to take that number to 20% if they don't think it's actuarially sound. I can't speak to the DPC side of that.
We've had people who've pushed back and said, we have 100 people and we have only 10 that are going to start with you. Again, if the plan is designed appropriately and there are incentives to send people to us, it doesn't take more than a year or two for those out-of-pocket dollars to drive behavior. There's old, long-standing data that shows most patients will change their primary care doc for about $10, which is highly offensive as a primary care doc, but it is the reality we live in. They assume that Dr. A, B, and C, unless they have a strong relationship with you, will do roughly the same thing, and it's their money, so they're becoming better consumers of healthcare.
So time for probably 1 to 2 more questions here, one here, one here. Just a quick follow-up on that to his point. Could you let the audience know about the average per member per month charge for DPC that you all are seeing?
So our list price is $89. Our employer price is listed at $75. And we go into about the $60 PMPM for some contracts. So just depends on what the volume is. Back to your point, If we think there's a low utilization, we can go down a little bit and it's included for everybody. The math, it's a max-min equation for calculus, and at some point it makes sense.
And what we see nationally is somewhere in that 60 to 125 range. Obviously, most of that depends on market. If you're in California, Colorado, Seattle, some of the higher cost of living markets, it's on that higher end.
Yeah, I think what I would follow that up with to his comment is typically DPC is a small percentage of that premium monthly for the employer that affects a huge amount of the spend. And so if they're looking to kind of nickel and dime DPC, we should be looking elsewhere in the plan design. I think Dr. Kendrick had a question here.
Related to that, I've had a bunch of conversations with brokers where they say, this is amazing. This is exactly what my people need. All we need to figure out is how you're going to pay me a 15 to 20% commission. So can you just tell me how that conversation goes for you?
And I, by the way, I owe Colton Storla, who's standing back there, as a broker who brought Excel Health Plans to my front door. So you have to tell them you need a more forward-thinking broker as part of it. But again, part of the structure is you can have those fees built in and say, here's our brokerage fee, here's the DPC fee. You can put that bundle together, and then everybody, if you want the plan to succeed, everyone's got to work together to get those price points to hit. So yes, I've had people who, and I was told early in my DPC career, probably the best advice I got, if they ask about a commission the first 5 minutes, it's not somebody you want to deal with. So, I mean, somebody who's looking out solely for themselves and not for the employer groups that they represent, those are not the people you want to be working with. So it's not all comers.
And I would say just quick on top of that, tell the benefits consultant to put their money where their mouth is if they're looking for more, and say, hey, I might tell the employer that I want a piece of whatever I save you on that self-funded side. That's a lot better way for them to operate, rather than say, hey, I'll take X dollars up front that I'm guaranteed. And then, if you save like that group that we talked about, $250,000 this year, then I get to keep, 10% of your savings for the first 2 years if I deliver that. And that's a much more effective way to tell a broker to operate.
We've done similar, where we've actually gone in and said, we'll guarantee X amount of savings, percent, 10, 5 million, and said, we'll guarantee these savings. If we don't meet it, we'll come back. But anything above that, you're going to share with us. And then at a certain point, you get to keep all the savings. So again, there are really big dollar items out there that if you're trimming just the routine marginal fat off of, you can make someone's plan look a lot better.
I think we have one more question, and I would just add a comment to that. If a broker approaches us and asks for that kind of thing, we say, when you get an MD after your name, then we'll pay you all your loan.
Thanks. Since COVID, we've hired talent wherever it is, right? So we grow as a company. We had 500 people in one location. Now we have 1,200 people in 23 states. How do I integrate direct primary care in that scenario?
So that's a great question, and there's a couple different answers for that. So I'll hop on the first one. And so there's a vendor here called Hint, which has the ability to network together direct primary care wherever it's available. And that will depend, whether or not that makes sense, also depends a lot on how big your company is, how many locations they have. If you have a 20-person company and you have 20 people in 20 different places, that might not make sense. But if, like you just said, you have 1,200 people and maybe you have 15 different locations with 60 to 80 people location, that probably does make sense for you to network together all of those parties. And kind of like we talked about in the first one, there's a couple different vendors like Resilient Health and a few others that can do a virtual primary care basis. So, we've seen many companies deploy, even hybrid models where, say, a company's headquartered in Des Moines and they have 100 employees in Des Moines and they have another 100 employees and they're absolutely everywhere. They might say, hey, well, on our employees in Des Moines, we want to provide those people with Exemplar care, but on our employees out of state, we're going to do a virtual based direct primary care, because that just makes a little more sense. it's a little easier for the HR manager, for the benefits consultant to deploy. And then especially, the hardest part can be education is, like I said, if you have 100 people and there's no consistency as to where those 100 remote people are, it could be very challenging just to educate those members. If you have 1 or 2 people per city, it might not make sense to network them together. So that's kind of on a how your company is built basis, but there's definitely ways where you can deploy the same concept and create engagement. And engagement, one of the best things that we find is using accident benefits. If anyone has heard of, that Aflac advertises all the time. I don't actually like Aflac as a product that much, but same concept. There's a wellness benefit associated in most accident plans of $100. So what we usually like to do is incentivize members with that benefit and tell them, every member, hey, if you go in and visit the DPC, get your physical done, you get paid $100 to show up, and then the brokers make more money. But the primary thing you're really looking for is getting member engagement to get them to show up, because we know if they engage, they will follow the preferred redirection pathway of the DPC.
Thank you all.